need to push down arrow and that's it. Hi everyone, I'm so sorry we're starting just a little bit late today. This is Valerie from marketing, Kelsey-Seybold Clinic, and I had to drive out to Woodlands today, and guess what? It was raining and there was traffic. So just a tad late, but we're still going to do the full presentation, so hopefully no big deal. So today is we're going to be talking about heart health in honor of February, which is American Heart Health Month. And I'm here at the Woodlands Clinic with Dr. Angela Ferguson. And she is an interventional cardiologist. She also practices at Spring Medical and Diagnostic Center, so you can see her over there too. She is certified, like a bunch of times, she's certified by the American Board of Internal Medicine for Cardiovascular Disease, the American Board of Echocardiography, and the American Board of Nuclear Cardiology. She has a clinical interest in the prevention of cardiac diseases, women's heart health, and interventional approaches for coronary and peripheral artery disease. That was a mouthful. In addition, she is besides being a doctor, she also does stuff in her private life, so she enjoys running, reading, and fitness. So I'm going to go ahead and give the mic over to Dr. Ferguson. Thank you for being patient, everyone.
Hello, everyone. This is Dr. Ferguson. Let's get started. So just to clarify, cardiovascular diseases certainly encompass more than just the heart. Coronary artery disease in and of itself can reflect whether it's a heart attack, angina, or arrhythmias, or sudden death. Peripheral vascular disease, that's where the leg may hurt when you walk a block. You have some muscle tightness and cramping, and the medical term for that is claudication. And certainly cerebrovascular diseases, which include stroke and transient ischemic attacks, which are also called mini strokes. And certainly high blood pressure, which is classified either by the top number or the bottom number as being greater than 140/90. And coronary artery disease, what is it? Basically, the arteries that supply the heart become blocked. Partial blockage can cause chest pain. Whether you exert yourself, it comes on, or even at rest. This is called angina. A complete blockage within the heart artery causes a heart attack. Atherosclerosis is usually the main proponent that causes coronary artery disease and blockages within the artery, and it's formed with calcium and high cholesterol are usually the main culprits of this, and it's secondary to inflammation. And in addition to that, other than this is showing how atherosclerosis occurs and plaque buildup and how the artery becomes blocked. In some instances, the plaque will rupture, and that will cause the platelets to stick, and it will cause a complete and total occlusion. Let's move on to hypertension. This is very prevalent in the United States. 50 million Americans older than 6 years of age have high blood pressure. 1 in 4 American adults has high blood pressure, and 40% of hypertensive people are unaware of it. It happens to be one of those things it's not painful. There's few signs that you may not have it, and the only way to get it checked out is by going to your physician. What is blood pressure? When the heart beats, it pumps through the blood arteries, and the pressure created within the arteries, it's called blood pressure. Hypercholesterolemia. This is diagnosed through blood tests. This is one of the main proponents for atherosclerosis, and it also depends on the number of risk factors for heart disease. What do the numbers mean? You can see a breakdown if you've ever had a cholesterol panel ever taken. There's total cholesterol, which takes into account both triglycerides, LDL, and HDL. LDL happens to be what we call the bad cholesterol. HDL is the good cholesterol, and you want that high. Triglycerides are a component as well, and certainly important. They're used to help make LDL. So the cholesterol goals in general, total cholesterol, you want it less than 200. The triglycerides, you want less than 150. HDL, you want it greater than 40. When it comes to LDL, if someone has less than 1 risk factor for coronary disease, you want it to be less than 130. Greater than 2 risk factors for coronary disease, which we'll get into the risk factors later. You want it less than 100. And people who have known coronary artery disease or diabetes, we promote getting less than 70 for the LDL. And high blood pressure. So why do we care about this? Certainly it can be a silent killer. Again, most people don't have any symptoms or signs of this, and it can be ongoing for many years. It has been known to be linked to heart disease, stroke, kidney failure, as well as blindness. The blood pressure, ideally, systolic blood pressure, that's the top number that you get when you have the blood pressure taken, and it's the pressure in the arteries when the heart beats. And the diastolic blood pressure is the bottom number, and that's when the heart is resting and relaxing and accepting more blood into the ventricles. Identifying risk factors for high blood pressure: age, gender, race, and certainly genetics. Risk factors that you can control. And this is for coronary artery disease. High blood pressure, diabetes, smoking, a sedentary lifestyle, obesity and being overweight, and the high bad cholesterol, which is the LDL. Or you could have a low HDL, which is the good cholesterol. Obesity. Researchers have found that 5,000 participants in the landmark, the Framingham study, which people were followed for over 15 years, and this evaluated risk factors for causing coronary artery disease. And after adjustments for known risk factors, obese women were twice as likely to develop heart failure compared to those who are of normal weight. Obese men had 90% increased risk. Overall, in overweight men and women, the risk was 34% higher than in normal weight individuals. And of course, overweight is classified as a BMI that ranges from 25 to 29, and obesity is greater than 30 for the BMI. Screening tools that we do to evaluate for coronary artery disease, certainly an EKG, and this measures the electrical activity that's going on within the heart. An echocardiogram, this evaluates the structure of the heart or architecture, and this does it by ultrasound, and we can also evaluate further the valves and the function of the valves as well as the wall motion of the heart. Stress tests, these are done either just by EKG on the treadmill. We can do echo stress tests that use a treadmill as well. And nuclear scans can also help show the response to the increased workload that the heart undergoes. And in addition to that, there's also ultra-fast CT scans that look at calcified plaques. This is, you might know as a heart scan. However, this doesn't test how the heart responds to an increased workload. This is strictly based on structure and looks at calcified plaques, and it cannot delineate how tight the plaque or the stenosis or the clog in the artery may be by this ultra-fast CT scan. Finally, angiography, where you go into the cath lab. This is the gold standard to evaluate coronary arteries. And the latest recommendations for primary and secondary screening, prevention, and therapy. So primary prevention, cardiac risk factors for coronary artery disease. Age, males greater than 45, females greater than 55 are at increased risk. Family history of premature coronary artery disease is a strong proponent for coronary artery disease, such as a first-degree male relative, less than 55 years of age, having heart disease, whether it was a heart attack or they had stents or bypass. Also in a female first-degree relative, age less than 65 when they had their first event, whether, again, heart attack or having stents placed, etc. Smoking, high blood pressure, diabetes, and an HDL less than 40. An HDL greater than 60, at this time it counts as a negative risk factor. You can count one off the risk factor count. And to evaluate whether or not you have high blood pressure, this is the classification that we have from the GNC. For the systolic blood pressure, normal, you want it less than 120, and for diastolic, that's the bottom number at rest, you want that less than 80. Pre-hypertension is classified for a top number that ranges between 120 to 139, or a bottom number that ranges from 80 to 89. Stage 1 high blood pressure is classified as a blood pressure for the top number greater than 140 to 159, or a bottom number that ranges anywhere from 90 to 99. Stage 2 high blood pressure, the top number greater than 160, or the bottom number greater than 100. The treatment for high blood pressure, first off, diet. It's important to maintain a low salt diet and get anything out of your diet that may, increase blood pressure other than salt. There's certainly alcohol intake does increase blood pressure. Exercise, losing weight, losing at least 10% of what you weigh can help reduce your need for going on blood pressure medications. If these factors do not work, you'll have to go on to medications. Finally, there are also some medications out there that do raise blood pressure, such as some of the antihistamines that we have out there, such as Claritin D, Allegra D, anything in the D at the end of it, that's pseudoephedrine, and it can raise your heart rate. In addition to that, it can also raise your blood pressure. And there are some herbal diet aids out there, as well as energy medications. Anti-inflammatories can raise your blood pressure. In addition to that, birth control pills can too. And finally, stop smoking. This can also increase your blood pressure. Exercise, 30 to 40 minutes of aerobic exercise is recommended, whether it's walking, bike riding, swimming, and it's important to state that this is sustained aerobic exercise. It's not like taking a walk through the mall and going in and shopping and then coming back out and sitting down. 30 minutes of sustained walking. The goal is 5 to 6 times per week. Certainly when you're starting out, start out at 3 times per week and then gradually increase it up to 5 to 6 times a week. And what you want to do is focus on exercise that gets your heart rate up for an extended period of time, which would be for that 30 to 40 minutes. Aerobic exercise also increases the HDL. Then, therefore, the HDL, as it increases, it'll lower your risk by 1 risk factor if you get it above 60. And women's HDL is typically higher than men. Diet, certainly touched on this briefly, but low sodium diet is very important, especially for maintaining a lower blood pressure. The idea is to get less than 3,000 milligrams of sodium a day, which means you got to avoid a lot of the canned food, frozen foods, and use salt substitutes instead. And I've been asked this several times whether sea salt is actually a good change out for salt. No, it's not. It's still salt. Low-fat diet, that'll help decrease down the LDL, the triglycerides, which is a main focus. Limit alcohol, as alcohol can raise blood pressure. Low-fat, low-cholesterol diet. This means lean meats, fish, skinless chicken, lean cuts of beef or pork, and then avoid high-fat dairy products such as butter, cheese, heavy cheeses, ice cream, basically all animal fats. Medications that we use to lower the blood pressure. The first class would be diuretics, such as hydrochlorothiazide or Lasix. Both of these are diuretics, and they do increase urination. They reduce the sodium through the urine, and it does relax the vessels. However, it can lead to increased cholesterol, electrolyte imbalances, and gout, especially when using hydrochlorothiazide in someone who does have gout. The next classification of medications that we use, beta blockers, such as Toprol XL, or metoprolol is the other name, or Tenormin. Both of these lower heart rate and they relax the vessels. However, the side effects, fatigue, cold extremes, depression, and sexual dysfunction as well. Another classification, calcium channel blockers, such as amlodipine or Norvasc, the trade name, and there's also Cardizem. These relax the vessels by lowering the calcium inside the vessel cells, and it can cause ankle swelling, flushing, as well as constipation. Another classification, ACE inhibitors, also relax the vessels by decreasing the production of a potent vasoconstrictor, or a chemical that constricts the arteries, may cause cough or allergic reactions. And then finally, ARBs. These also relax the vessels, and they block action of potent vasoconstrictors similar to ACE inhibitors, but not through the exact same pathway. And so far, side effects haven't been reported any more than the placebo. So other medications, statins that we use for lowering risks for coronary artery disease, these specifically lower cholesterol. They lower LDL. They can increase HDL and lower triglycerides to an extent. However, they're more potent in terms of lowering the LDL. They have been shown to decrease mortality in patients with coronary artery disease. However, it's very important with any statin medication to check liver function because it is metabolized through the liver. And also report to your doctor any new muscle aches or pains you may have, especially when you're on a statin medication. And important, when you're out there at the grocery store and you're wondering what has low salt or how much fat is in a product, take a look at that little box in the back that most of us ignore sometimes. Look at that, and that'll have the nutrition facts reported on there. And most importantly, quit smoking. This is really one of the most important preventable causes of premature death in the United States. It accounts for 440,000 or more of the more than 2.4 million annual deaths per year. The most important risk factor for young men and women who end up with coronary artery disease is smoking. It produces a greater relative risk in patients under the age of 50 than those over the age of 50. And certainly there are multiple risk factors that increase cardiovascular deaths. However, by looking at this screen, the green line, that's on the lower end of having your frequency of death. Non-smokers have the least problems with having cardiovascular deaths, whereas you look at the smokers who also have high blood pressure, they have the highest risk of coronary artery disease deaths. And that's the yellow line at the top of the screen. So important take-home points. Lowering your risk of heart disease, it's based on lowering your controllable risk factors, which would be the cholesterol, the smoking, the weight. And also changing your diet around to a heart-healthy diet, which is the low-fat, low-salt diet, eating more fruits, vegetables, starting to employ a good exercise regimen that you can stick with. It's important to build up your tolerance and do things that sustain your heart rate for a good 30 to 40 minutes continuously. Take your medications as prescribed, and most importantly, please talk to your physicians if you have any side effects to these medications that you don't find that you can tolerate, because it's important for them to know versus just stopping the medication cold turkey. In addition to that, discuss low-dose aspirin as preventative therapy with your doctor, whether or not it might be a right choice for you, and get regular annual physical exams for preventative and screening and care. And now we'll go to the question portion. Okay. So the first question we have is, what is peripheral artery disease? Peripheral artery disease is classified as the arteries that either go to the arms or legs that have buildup of calcium. Typically, the signs of peripheral artery disease could be something such as described before as claudication. In the legs, it's going to be more noticeable, say, than in the arms because you're out walking and using the muscles of the legs more. And the types of symptoms people feel from it, say after walking a block, they have muscle aches, pains, kind of muscle fatigue, could also be cramping. And it's relieved by rest. And a lot of times people who do have significant peripheral artery disease, they can get back up and walk a little bit further than what they did the first time. And here we have another question. The question states, is it true that heart disease kills more American women than breast cancer and cervical cancers combined? That is true, and unfortunately heart disease in women, it goes unnoticed because women don't necessarily present with the same exact or the classic symptoms of coronary disease, such as clutching your chest, bending over, you have the pain down the arm, shortness of breath. Sometimes women, they wake up in the morning, they have nausea, vomiting, and maybe pain down the left arm. Or they could just have a symptom of shortness of breath when they exert themselves, which could also be other reasons for that as well. But it does go unnoticed sometimes in women. Or they may just account their symptoms as being indigestion. Next, we have, what does benign hypertension mean? Benign hypertension means, one, it's from an undiagnosable source because there's many reasons of having high blood pressure, such as kidney arteries that have plaque buildup in it. You can have high blood pressure from that. Usually it is treatable. Okay. So what is the proper way of getting off your blood pressure medicine, and how can I get my doctor to agree to try to wean off a blood pressure medication? So the best way to discuss with your primary care physician with regards to getting off of blood pressure, one, make sure there's no other needs for being on the blood pressure medication. Sometimes blood pressure medications are used in diabetics to help prevent their kidneys from shutting down. It helps protect them from the high sugars. Also, if someone has palpitations, the beta blockers have a tendency to help suppress those palpitations. But the best way to do is to keep a blood pressure log at home and show them that the blood pressure is staying low, and maybe they'll want to start to wean you off at that point in time. But certainly there's other reasons for having high blood or being on blood pressure meds other than just high blood pressure. Next question, can plaque ever be removed from the arteries? No, plaque cannot be removed from the arteries. However, there have been some studies that we've done on carotid arteries that have shown if you're on a statin medication, one that lowers cholesterol, if you're on it and your LDL goes less than 70, you may have some plaque regression in some people. But in an effort to reduce plaque completely from the arteries, not yet. I'm sure that's something that is in the works. So I have another question. Someone's asking about having the EBT heart scan, which is the CT scan that looks at plaque in the heart. Really, it's one of those that people do get, especially at some of these health fairs. It doesn't tell you about the physiology of what's going on in the heart. And if someone's not having chest pain, chest discomfort, I have to admit it's not a very helpful scan at this point in time. All it can tell us is if do you have calcium or do you not. And if you're asymptomatic, at that point we aggressively start treating for risk factor modifications such as high blood pressure, cholesterol, getting the cholesterol to less than 100, more ideally less than 70. But all it can tell is it has calcium, but it doesn't tell us how significant the blockage in the artery is. So I have another question here. Is white coat syndrome related to hypertension? This is when people come in, they say that they come in to see the doctor, they have the white coat on, and their blood pressure increases every time they come in. Certainly anxiety does play a component into that, or nervousness about what the doctor may say. Could be related. However, if anyone's blood pressure still goes above 140/90, it's still a concern because it's probably doing that in the outside world as well at certain times. The blood pressure is labile and it is influenced by external forces such as what's going on if you're nervous or stressed out, certainly salt and all those other things, but it's still one of those that it does need to be treated. So I have here a question, how does an interventional cardiologist differ from being a conventional cardiologist? There are a lot of cardiologists out there and there's a lot of hats that we can wear. An interventional cardiologist describes someone who has been additionally trained to go in either coronary arteries, peripheral arteries, carotids, etc., but we can perform an intervention such as putting in stents, ballooning open an artery. Those are the kind of things that we do versus a conventional cardiologist, which they typically focus on more of the diagnostic end of things, echoes, nuclears, seeing patients in the hospital, and they can also do diagnostic heart catheterizations as well. But if anything needs to be done to an artery, that's referred over to an interventional cardiologist. And I just wanted to thank everyone for their time today, and thank you for all the great questions. Have a good day.
All right, thank you everybody for joining us today. Please make sure you join us next month. Dr. Dillon of our main campus and the Women's Center is going to be presenting Female incontinence, do you have a going problem? And you can go ahead and register right now online at Kelsey-Seybold.com/webinars. And there were some questions about getting the slides after the webinar. Well, at that URL down there at the bottom of the screen, you can also watch the webinar and view it as many times as you want to. It will be posted on at that URL, Kelsey-Seybold.com/webinars. So that's where you can find it. Thank you, everybody, and have a great Wednesday.